All right, so my name is Austin Bach. You'll hear from me next, actually. We just want to introduce our Alvin Dubin lecturer, Matt Lorenz. He is a medical retina and cataract surgeon in Knoxville, Tennessee. He's going to be speaking something near and dear to my heart, actually. We're going to, as you can see, speak about artificial intelligence. Very happy that he's here. He'll bring his brother next time. Matt.
Thanks, Austin. Appreciate it. All right, great. Don't have to clap just yet, and you don't have to clap at all. But artificial intelligence is kind of a broad topic. But we're going to get to it. They require us to put in a financial disclosure slide. Every time I do a talk, I love this slide in particular because I like to say, if you think that I'm trying to sell you something, then get on your phone, scroll, walk away, whatever. I'm not, and you can tell. I have no interest in that. I do own stock in Lumada Health, and I think that's probably why, I was reached out to, because we're doing a whole lot there, and I'll tell you my story about that in a minute. But I'm not selling anything. I have no interest in that at all. I can't stand boring lectures, so I'm going to try to be interesting. But if you do doze off, no worries, go for it. And I'm a practicing physician, and that's the part that I like to put in here, because they make us do this financial disclosure as though doing so is going to decrease the bias. Well, everything we talk about and everything we do has a financial impact, because raise your hand if you do this to make a living, all of us, right? So I always point that out to say there are financial impacts to everything we do. And if we're talking about artificial intelligence and it's going to take over the world and take over our jobs, it might have a little bit of a financial impact. That's a little bit of tongue-in-cheek there. So, Dr. Dubin, a lot of words there. You can read that faster than I could say it, but Dr. Dubin is a massive giant in this organization, and because of his impact, we're here. And I remember coming to Sarasota as a third-year medical student and kind of being, oh my goodness, I didn't even know this thing existed. I found out about it, and I showed up, and I not only was welcomed into it, but then encouraged as a resident to participate, to be a part of this, and it had a huge impact on my career. And then I got to be a part of some leadership committees and work with him while he was on there, and this is just an honor for me to be able to speak in his named lecture, and I really hope that I do him a good service. He's been huge, and I think that's important that we mention that, and it's an honor for me to be able to speak with his name here. So hopefully you've read that by now, and he did a whole lot, and we're here having these organizations because a large part because of his impact. So thank you, Dr. Dubin. Also, thank you to the program directors, residents, my program director in particular, who's not here, and then my other residents. Some of them might be here that gave us a chance to train and learn and be here. And it's really interesting in my mind that I'm up here talking now when I used to sit out there going, God, that person's boring or whatever. But it really does come full circle when all the efforts pay off and all of the hard work and the things we do, they matter. So thank you. Thank you for your attention. Thank you to the program directors. Thank you to the residents. Okay, here's the learning objectives. When we were going through, Dr. Gossage was my program director, and he forced us to create these talks, and we did them every week, and I'm like, I hate public speaking, and he's like, good, you're going to do a lot of it. And then he also made us come to these meetings and do the lectures here, and by the end of it, all the residents that came through that program got, pretty good at it and comfortable, I should say. Not necessarily good, but comfortable. And one of the things we talked about was don't put too many words on the slide. There you go. And I did that. And so a lot of the talks I would do would have like a picture, and then it'd be a conversation. This one's a little different. So my intent was to put a whole lot, because there's so much information. And one thing I also want to say is artificial intelligence. By the time I just started the talk a couple minutes ago, by the time I finish in an hour, there's going to be so many things that are probably outdated in that hour. It's moving that fast. And I don't say that hyperbolically. It's moving that fast. So if you get a copy, if you can, hopefully it's just a quick throwaway where you can read a whole lot of the information I put on there that I think is useful, just to read it and then throw it away. That's why you'll see a whole lot of words on there. So, but if you do want me to read them very slowly and boring, I can. So the goals. I want to be conversational. I want to discuss AI in general, because if you've been to some of the specialty societies, especially at the American Academy of Ophthalmology and others, there's a lecture on this, but it's very narrow, it's very focused, and it's very data and frankly kind of nerdy, and a lot of it I go, I don't understand what's going on. So I'm trying to fill in a gap of what I see in those lectures and go, what about this? And ask some questions or even pose some ideas. I don't want to be boring. I'm going to try not to be. And then also, too, we're going to zoom out and kind of do a big picture on AI. And I went down a rabbit hole several months ago when I started doing this, and I'm using you guys to help me get out of it because you'll go nuts. But we'll zoom out and look at AI outside of medicine just a touch in how I've learned to sort of understand it better and how to put it in a framework because it's just flying at us quickly. So, and it made me lose sleep. So my hope is to invite you into the misery that I've been going through the last several months. And Lumata Health is a company, we started it a long time ago along the idea of doing some diabetic retinopathy screening, and can we do a data-based approach to this? And it's sort of morphed into totally nothing like we originally started, and it's using lots and lots and lots of data science in order to do things. And the people mentioned here, I don't want to go without mentioning their contribution because they're PhDs. And the field, our field, ophthalmology, is being flooded. Medicine in general is being flooded with PhDs. And there's one university, which I won't talk about, their Department of Personalized Medicine has 0 clinicians in it. I think that's a problem. I think clinical care, taking care of people, should have clinicians leading it. I feel very strongly about that, actually having dove into it a lot. So they contributed a lot to this and the information. So technology doesn't help people, it helps people help people. And you'll see that phrase throughout this whole thing. And when Lumata Health, it used to be called retinal care, but when we started that was a phrase I put out forward. The technology is coming very quickly, but at the same time, technology doesn't help people, it helps people help people. And I found that to be a principle that's true. I'm going to talk about where I've come in this story, again, invite you into the misery of what I've been over the last 4 months, 6 months or so, what our practice is doing about AI in general, kind of an overview of AI terminology to try to understand it, because like I said, every time I go to these society meetings, they'll talk about it and they'll use words, and I think they're very big words and they're so smart, but what does that mean? What is a convolutional neural network? I don't understand that. So I'm going to try to make it really digestible for clinicians to understand what's going on. The history of AI. Does anybody know how old artificial intelligence is in general? Think about it. You're talking 60, 70 years old. I mean, the actual field of it. So, and then AI and eye care, and then that zoom out, we'll talk about that, just for a better understanding of what it is. Scott Westhouse, he's not here. I told him, I said, I'd really like you to be there because I want to embarrass you. And it goes back to, I was at a meeting in Chicago, probably 2018, 2019, and I like to play around on the farm. I'm not so much of a tech guy, but I love what I do and I love being in the clinic. And he says, hey, man, because we were talking about how everything's moving and how quickly and what can we do better. I want to see 500 patients a day. And then we're like, okay, let's figure out how to do that. You need a computer, you need imaging. And how many times do you go in and you see a patient and say, I know this patient, I know what to do and everything. Before you even go in and see him, then you got to go through the motions, right? AI is allowing us to close that gap. And of course, that's very, an impersonal way of looking at it. But at the same time, that's where we're going. And he talked about that, we talked about that, and he said, have you seen AlphaGo? And I'm like, what are you talking about? What does that mean? He said, you need to watch this documentary called AlphaGo. Has anybody heard of that and seen it? It's Google's DeepMind, their AI program to play the game Go. I didn't even know what it was. It's apparently the oldest board game known to man, and it's the most complex, the game of Go. And I watched that documentary, and I'm like, Scott, I'm going to kill you. Why am I watching a documentary on this? By the end of it, I'm just emotional. I'm into it. And that's my first wow point with artificial intelligence, to see how it's going to affect humans. And then the second one, working with what's now Lumata Health, we figured out that we can look at data. I can get 6 points of data and tell you the risk of you having vision-threatened diabetic retinopathy with 99% accuracy the rest of your life. And those 6 data points, 0 of them come from an eye doctor. I saw that happen, and I go, this is a big deal. So that's my number 2 point, where I go, this is not I'm sitting on a tractor goofing off kind of stuff, and I'm going to get up and my job's going to be the same for the rest of my career. This is a big deal. So that's where I've arrived at this artificial intelligence. It's kind of a thing. So 2022, here's the American Academy of Ophthalmology artificial intelligence section. Boom, 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 boom. These 5 lectures, those are the topics. And I'm like, solving the last mile problem, the last mile. I'm just now getting in here thinking, what are you talking about? And that in particular was talking about how Lumedix Core, which was like IDX at the time, came out, and they were very specific to that instrument, that camera, as opposed to being able to apply the technology across the board. So that's in 2022, and this is in 2024. The lectures have changed, but they're very narrow. They're still kind of in this narrow data. And like I said, I'm trying to fill in those gaps of, I don't want to be too nerdy. I want you to hopefully walk out of here and go, okay, I kind of get it. Here's where it's coming. This is what it is, and have a framework of what it's like more than just another thing that goes in our office and does something. So what are you guys doing about AI in your practice? Do you have a policy? Do you have somebody in charge? Do you block websites? And is anybody doing anything at all? Have you thought about it? Anybody? I didn't even know it. And in our practice, what we're doing, our group, we have this committee that was put in place, and I took it right off of their charter, stuck it up there if you want it. So, and I can get this too if you want, because I got permission to sort of share that if you'd like it. And it just says, we see that it's there. We're going to do things to try to, ensure privacy and those things. And then also, again, a lot of words. I don't need to read that. But a generative AI policy. Has anyone taken, of course, protected health information, not do that, but put in patient information into a ChatGPT or a Grok or anything like that and see what it can do? Have you heard the case of a patient who put their MRI into ChatGPT and the doctor missed something? I mean, that hit the news. I did it. I started doing it as though I was back in residency, and I'd present the patient to the AI platform as though I was presenting it to my attending, and it blew my mind what it came up with and what it showed me. It's fascinating. So what is AI, right? Think about it from what do you think of it is, and what is your point of reference on how to do that? And then we're not going to define these terms, but you need to. What does it mean? We're going to be forced, and we are being forced. What is intelligence? What does it mean to know something? And you may be thinking I'm crazy, but we're being forced to define those in ways we hadn't really thought about because we just keep on going. So think about these terms, think about AI in your mind as we go through this. So what is it? It really is the development back in like the 50s of the idea that a machine could function and learn or have an intelligence that was at the level of human intelligence. AI, machine learning, deep learning, they're often interchangeable, but they mean very different things. And so these pictures at the bottom, think of it as grouping things together, clustering. So if the computer will see a whole group of things, it may group them in like subsets. That's one example. This picture here, deep learning is a lot more in-depth than machine learning is, which is a lot more in-depth than the broad term of artificial intelligence. Then you have specific things like natural language processing, computer vision, and reinforcement learning. And so I think it's worthwhile to look at these and recognize they're not just synonymous with each other, especially if you start talking to data scientists and people in this. It's different. Those are different terms that mean something very different, and we go, oh, machine learning, deep learning, AI. It's not the same, but we oftentimes do that. What's a neural network? So most of the newer platforms in all of data science, whatever, use neural networks, specifically in ophthalmology, because it's based on the idea that you have a neuron, and then it forms a connection with another neuron, and then another one, and then another one. And if you get an outcome based on that, then that neural pathway is strengthened. If you get a bad outcome, then that neural pathway is weakened. That's it, and that's the understanding. That's our understanding of what we think our understanding is. Then they apply that to a computer, and it's the same thing. You got a neural network, and then you take that and you extrapolate that and multiply it times a gazillion over all these different possible outcomes, the good outcomes get strengthened, the bad outcomes don't. And that's the foundation of how these neural networks are put in place. Specifically, what is a convolutional neural network? That is, as it says, it's a deep learning model, so the most sophisticated model of pattern recognition, image recognition. And what do? We're ophthalmologists, we look at pictures all day, right? So we just have this image, and the computer has figured out how to look at, interpret, and see those images, and it's better than us. If you didn't know that, I hate to be the one to tell you, but it's better than we are. Raise your hand if you can look at a retina and go, that's male, that's female. I can't. Now I look at a bunch of retinas, but the camera can, the machine can. Smoking status. I mean, you can usually tell when you walk in the room, but when you look at the retina, can you tell what and if and how long they've been doing that? And we're going to talk about a term called oculomics. Is anybody familiar with that term? It's using, we'll get there. So, examples of a convolutional neural network, back to neural network, strengthening good outcomes in those neural pathways, weakening the bad ones. That's a basic understanding of what a neural network is. And if there was a data scientist, they'd be like, no, that's not, I've been on the phone with them before going, tell it to me like I'm a fifth grader. And then as soon as they get into the clinical, I go, you guys need to be quiet. That's what I was saying earlier. I deeply believe that clinicians need to be leading the way in technology taking care of people, period. And we as clinicians need to be very aware of that. Supervised learning. So you have to train these. So for instance, you take the ETDRS data set of all the pictures, you plug it in and say, I remember Dr. Goss is telling us, he's like, well, that's better than photo 2.5A or whatever. And basically you take that data set, put it in the computer, and the computer will tell you, based on that learning data set, is this picture like one of these or not? I mean, that's how we learned. We learned what mild, moderate, and severe diabetic retinopathy was based on images and classifications that were done by the reading center. And you take that data set, plug it into the machine, it learns, and you have to have supervision and labeling of those images in order to get good outcomes on the other side. And everything's about data. So history of artificial intelligence, 1956. This was where I was a little bit surprised. So this is not a new idea that a computer could possibly learn, like, the idea of these cyborgs coming in and, that's old school movie kind of stuff. But it was sort of founded in the 50s. And then there were some limiting factors along the way that kept it from sort of becoming mainstream. But that Dartmouth meeting is widely believed to be the founding meeting of AI as a field. And then zoom forward, and you get some money here going in there and funding it, and you get things that come about. But the big one to me is in 2017, you had transformers. Transformers basically take the idea, you can put some input into this transformer, and it looks at a sentence, breaks it down, and not only does it just take it and recognizes it, it recognizes it in context. Matt is on the stage giving a talk. It no longer isolates each one of the words. It said, who is Matt? What is he doing? He's giving what is he giving? How do you give a talk? And all of these things take place within that transformer to then give an idea on the other side to interpret it. That's huge. And when you take that, the T in GPT is transformer. And that's the model of a neural network that's being used to generate all of this information and put it into text. And these generative or generating large language multimodal models, they now have emergent capabilities. And what does that mean? And you can find this on the internet, but they had these models where they saw sentinel neural nodes that would pop up, and they were like, we didn't put that in there. And it learned, one of them is Amazon reviews. So it was looking at the Amazon reviews of products, and then a sentinel node had emerged of whether people felt good or bad about the product. So the computer figured out whether people felt good or bad based on the product on its own, and that was not put in there by the people doing it. So that's occurring. That is happening. And those emergent capabilities, so you've got transformers, emergent capabilities, chips Computer chips is a little bit of a limiting factor, but it's another big step that's really put things into motion. And then now everything's about electrons. You've got Amazon and these other companies going, hey, we need a nuclear power plant. Oh, great, that's good for society. No, just for us. We need to run our computers. We need a nuclear power plant, because if the more electricity you put into it, the more data and the more compute, you can scale beyond our own imagination. I'm trying to stay focused here. So, history of AI, large language models, that's where we are. And you can get on any one of these AI platforms and say, tell me what is out there, and then it will list it. So I just put it in there because it's a list of all of the places you can, or some of the places you can go. There are more than this. So, image, videos. Anybody a musician in here? Have you gotten on Suno? S-U-N-O? Yeah, it's amazing. You can write me a song about giving a lecture at an ophthalmology meeting on artificial intelligence, styled like Darius Rucker, right? Whatever. And there you go. It's going to pop it out, and it's there. It'll give you 2 of them. It's immediate. It's insane. It's really cool. And then artists, talk to artists. It can do things that we never even thought. And then in healthcare, that's kind of where we're at now, talking about what impact does this have on healthcare. It goes back a long ways. And if you look back into the 70s, it was originally designed to go, if then. If we have this problem, how do we provide this solution? And it would pull blood samples, and it would try to find, solutions to be able to look at infections and treat them. It took a whole lot of time to develop. Now we can do it in days. And in 1979, there was an actual organization that was formed. And then early, you were looking at it that way, where you would say, hey, there's an infection. How do we treat this? And then from there, it goes forward. And now in the last maybe 10 years or so, it's just gotten pretty insane with neural networks. Again, ophthalmology, eye care is ideal for this, because the ability to just recognize images, it's way better than we are. So where's it going? Personalized medicine. You can tailor a person. Yes, we try to apply the research that we know about and the evidence to have the standard of care on how we take care of patients, but that's a very broad approach to an individual. We know that instinctively as a clinician. This person, the statistics are either 100% or 0%. Did it work or did it not on you? Statistically, that's all or none. But yet we're applying this large group of data. What if we could personalize it? Well, we can in ways that we never even thought possible. That's where it's going. Earlier detection of diseases, more reliability of, remember, clustering. You can classify diseases differently, and it may be able to look at things in ways we had no idea we could before. So it's getting really exciting. Drug discovery. I live Knoxville, Tennessee. It's pretty close to Oak Ridge. They've got a supercomputer there, and so everybody tries to get time in there to do really cool stuff on the supercomputer. And during COVID, there was this block time where people from who knows where were coming in there, running models to try to find ways to treat the disease, to detect it and then treat it. And it was an interesting time, because people would come out and go, you're not gonna believe what we saw. And then they wouldn't talk about it, and then that's all I got. So anyway, machine learning tasks. It can do all of these tasks way faster than us, way better than us, because it can look at data points. Here, do this in your mind. When you look at an eye, try to list all of the data points you're looking at, right? How many can you get to? The computer's looking at hundreds, if not thousands, in milliseconds, just all at once. And I did it one time, and I think I got to 15. That's not a lot. So, eye care, specifically. We're in a unique position as ophthalmology, because I said, we look at pictures, right? Images. We look at images. And its ability to do that is way better than we are. Now you take the diseases. Can I beat up on us a little bit? It can stay in this room. So glaucoma. We've got, sorry, Austin, I'm beat up on you glaucoma guys. What have we really learned about glaucoma in the last 40 years? Truly. What have we learned? How to put stuff in the eye, how to lower the pressure, and all these We got a gazillion-dollar industry of MIGs. Somebody's going to meet me in the parking lot and take out my knee. Well, what are we doing? We're lowering the pressure. Okay. Congratulations. We were kind of doing that before. But what have we learned about the disease in a meaningful way? Truly, I don't know. I hate glaucoma. That's the one I hate the most. And I don't mean I hate it like, God, I just look at it, and when you got a patient who's 25 and they go, I didn't know what's going on. I can't see, and there's nothing I can do. I mean, it's very different. I'm a retina guy. When you've got an 85-year-old who gets geographic atrophy, it's terrible. But there's no but. It's all terrible. I wish no one ever went blind. But glaucoma, seriously? Normal tension glaucoma. Even worse. It's like, there's this thing that's associated. I always start out like this. Well, glaucoma, let's define that, right? Glaucoma is optic nerve damage over time and associated with pressure and other things. And they're like, but my pressure's normal. And I'm like, yeah, but unless there's pressure. I hate that because you're sitting there going, I don't know what to do. And I mean, it's a little bit funny, but at the same time, you're sitting there going, I get to go on to the next patient. This person has to live with this, and we can't do anything about it. And we don't know any more about it in 40 years. I'm getting to everybody else, okay? The retina. Really? Anti-VEGF is fantastic. It's amazing. I saw Avastin patient number 1, Eylea patient number 1, Lucentis patient number 1. I've seen their eyes. I know their families. It's the ones in the trial. I know the story in a way but we're not curing the disease. Don't get me wrong. It's huge. That's part of the reason what got me into wanting to go to retina, because it changed people's lives in unbelievable ways. But do we have a further understanding of macular degeneration, really? And geographic atrophy? We're injecting people to stop geographic atrophy with $2,500 medicines? Give me a break. They did a survey, and if I'm offending anybody, kind of don't care. They did a survey, 4,000 retina specialists in the room, and they said, is this an acceptable treatment? 83% immediately said, no, it's not. But yet here it is, and we're jacking people's insurance and charging all this money for what? And Dick Spade boiled it down to one photoreceptor is what you're changing. So AI, please help us do a better job of understanding these. Help us do a better job of understanding these diseases, please, okay? I'll take that all day long. So I'm not totally beating it up. I don't want a cyborg to kick me out of my office and do everything for me, but if I could spend more time on the farm, that'd be great. Diabetes. We're better at that. We're detecting it earlier, but how many of you seen a patient who you've injected or seen, or please make this go away, and it just won't go away? One other thing, can I just speak off the cuff? How many patients do you have with diabetes who go on dialysis, they get on dialysis, and then their pressure, and they like tank, and you don't know why? Is that new? For me, I've seen, that wasn't a thing that was a huge, but I don't know if there's something different in the last 5 years. I don't know. I need to stay focused. So diabetic retinopathy, AI is doing a massively better job than we are at detecting it, classifying it, and seeing it earlier. And so screening programs, we're a part of a huge primary care group, and they have cameras, and they're doing a fantastic job of detecting it. And really, the retina specialist, the interventionalist, if you're treating diabetic retinopathy, only 4.6% of them need to be intervened upon. That's vision-threatening diabetic retinopathy. The rest of them, take the camera. Good. So, vein occlusion, same thing. Glaucoma, specifically apoptosis in these cells. When you look at this is dark technology, or a detection of apoptosing retinal ganglion cells. So it's a little bit of a research-based technique, but it can detect cells that are starting to die off as an early sign of glaucoma. AI can pick that up using some imaging techniques, but we can't do that. That's good. The ganglion cell analyzer on the OCT does a good job, but this is like way ahead of that. So AI is great. Detection with deep learning. And so these pictures here, I don't know if you see that. Those three, pay attention to that. There's something called AUC. It's a statistical term that means area under the curve. The higher the area under the curve, the better. And so let's start here. C, That's the clinician. Pretty good area under the curve. We're pretty good, and that's like a linear distribution of that, like of 50% bad, 50% good. The area under the curve is higher, the better. C, right there, is clinicians. That's us. B is the deep learning, looking at the imaging models, and then the AI detects it. A, data alone, just looking at data. No imaging, no clinician, just data alone. It's pretty good. It's really good. And this right here just points out that you're talking about sensitivity, specificity, high 80s, low 90s. That's better than we are. Yeah, there you go if you want to take a picture. Hopefully you can get a copy of it. And then another thing we did at Lumada, we like to sit around and think, and I think that's undervalued in our society today. But we do that, and we came up with this smart dropper. So it's a drop that basically it has a pressure sensor on it. You can tell when the patient picks it up. You can tell, put it in their pocket and walk. You can say, hey, they're walking this fast, and did they use it or did they not? And they have to charge it, and you can tell if they squeeze, and you can learn a whole lot about it. And so compliance is a big issue, right? The whole gazillion dollar MIGS industry is like, oh my goodness, they're compliant. They're not ever going to have to take drops again because we jammed these things in their eye. And so compliance is a big deal. This smart dropper is pretty neat. The AI can analyze the behavior of the human, just like your phone walking around. It'll detect all of those things on there. So it's got an accelerometer and then a pressure reducer that tells you if you're holding it and when it's moved. It's really cool. AMD, we'll get to it, but Notile Vision, it's not nodal. They say Notile when you talk to the company. That's what they say. It's an at-home OCT monitoring system. AMD, structure and function. Right now we're looking at a 2D slice, and then you scroll through and you kind of imagine the 3D, or if you pull up the 3D, that's fine, but what about the volume? You're looking at the volume of the fluid? The Notile Vision system, you can put parameters within the volume of the fluid to say, hey, you're going up higher, not just the 2D slice. Central retinal thickness, I've never really liked that. You have to have something in studies to be able to mark, but central retinal thickness, I don't care about that. It doesn't tell me anything. But the volume of fluid, that tells me a lot. That's a big deal. Structure and function, and we have OCTs and are watching AMD. Geographic atrophy, monitoring that and the growth of it. AI can detect things we can't. This is fantastic. Over 40% of the people that are being treated for wet macular degeneration were massively overtreated, according to the studies that Notile Vision is coming up with. Deep learning, again, you take a data set, the ARIDS data set of all the pictures, plug it into the computer, train it, supervise it, and next thing you know, you've got all of this computer able to detect and diagnose and treat and classify and tailor personalized treatments very, very, very well, especially with the volume of fluid from that home OCT. Diabetes. Does anybody know a family doctor with a camera in their office taking pictures? Good, bad? Any thoughts? Kind of mediocre? We're in a big primary care group, and so part of me is like, absolutely go for it. When we started that company a long time ago called Retinal Care, we were doing it with ERG. Kind of a funny story. The Redival, LKC's device, Redival, we were involved in helping that get FDA clearance. And so what we did was, this is a story that should be told by Steve Franson, because he did a lot of this, and he would laugh and tell me not to tell it, but he's not here. So what we did was we put all this data in, and we said, you know what, we have the data, ERG and diabetic retinopathy, CRVOs, things like that, very well documented, very well established. And so we did signal processing and looked at it and came up with a score. Basically, if it's above here or below there, do you have vision-threatening diabetic retinopathy or not? 99% specific, 98%, better than humans. We just said, here, take this data to the FDA, trying to get the device approved. And they said, this device is amazing, it's fantastic. And it actually really is a good device. If you want to do an ERG, way less cumbersome than the other ones. It's a really good thing. But then they said, well, you cannot have a device tell you classification of disease. And we're like, okay, bummer. And then we just sort of kept that data. We knew, we just were like, let's see what they do. Put it in there, and they didn't like it. A year or two later, Luminetics Core now is their name. They came through, and they're the first ones to do it. But I think we Steve Franson poked the bear with AI, and diagnosing through that ERG. And I just think that's very fascinating because the ERG gives you so much information, and you get some of the signal processors, those PhD, to do an analysis on that, you're getting all kinds of information. Then you take that, you couple it with a fundus image, whew, all kinds of stuff. So IDX-DR, it's now Luminetics Core. That was the first one, and I think the fact that it's the first should be mentioned. So other examples, this is not all of them. There's a bunch, and like I said, by the time I start talking, by the time I finish, there's probably going to be some updates in this. This one is really interesting because you can just send your images up to the cloud, have AI do it. It's doing a fantastic job. iNook, I think is what they're calling it. Just doing a simple acuity test, better than Snellen. Anybody have any trouble with getting their patients to do that, or their techs? It looks exactly the same as the last 5 exams. Yeah, anyway, COVID-19. This one was interesting. You take a photo, and you can detect whether they have COVID or not, and they did screenings, and it was, hey, wait, the eye might be a biomarker for other disease. Oculomics, that's what this is. It's kind of an emerging field that uses the eye as a biomarker for systemic disease. It's extremely powerful. Fundus image compared to coronary calcium, do a fundus image, don't expose them. You can see statistically just as good or better. Stroke risk, fundus image tells you so much. And yeah, read all that if you want to. Get a copy of it, but that's oculomics. You're looking at metabolic profiles, you're looking at proteins. AlphaFold, Google's AlphaFold, have you heard about that? It's an artificial intelligence predictor or analyzer of proteins and the way that they fold. For medicines, everything's a biologic nowadays, right? So they look at how proteins fold. It's really, really, really interesting. So FDA-approved devices, you know, here there are some here, there's others. There's always going to be some coming out because it's a huge, huge, huge opportunity, if you will. But data. AI needs data, absolutely needs data, and not just data. If you just throw a bunch of noise at it, it's going to, you know, garbage in, garbage out still applies. So you're going to have some trouble with the outcomes based on what that is, hence the need for supervision, hence the need for labeling, because if you don't label the data set, then it's going to kick out some bad data. Data availability. Has anybody noticed that we have the access to more data now than we ever have? So does the amount of information that the human brain can process, is that relevant? I'll get to that in just a second. Data collection is crucial. Anybody ever participated in research? They just beat you up. I had 10,000 charts, and they were out of that 10,000, we ended up with like 110, including the study. So we had to really go through. Now, if you could take AI and do what took me 8 months in a few days and get this, yes, I don't even want to go there. Drawing with a mouse, geographic atrophy. Drawing with a mouse, the drusen. Like I said, I'm inviting you into my misery. That was not fun, but it was very valuable. Anyway, data bias, same thing. You've got to have good quality data that goes in to be able to train it. For instance, if you only go to East Tennessee, you're going to get a bunch of white people. And how's that going to apply when you take that over to China and apply that same? It's not going to work. Getting a larger data set, sample size, population, things like that matter. So, turns out that the amount of information that the human brain can process was irrelevant and didn't matter for 99% of human existence until June 29th, 2007. Anybody know what date that was? It began on that day to be different because that's when the Apple iPhone came out. So the access of information to the human brain went up so high that information came in. And we never knew, never cared, it was irrelevant how fast the human brain can process information. It turns out it's 41 bits per second, and it turns out that vastly more information is flying at us than we can process. And then you start thinking, well, our brain isn't an information processor. It actually is a huge filter saying not relevant, scary, no, and only taking in certain things. That number and that concept applies from now forward in all of the technology that's happening. We can only take in so much as humans. The computer can process all of it all at the same time. How does that matter? I don't know, but it's interesting. So another thing it needs, like I said, you got companies going, we need to put a nuclear power plant right here. We need to be close to this river because our computers get so hot, we need to siphon off the water to cool it down and then spit it back in the river. That's one of the limitations, is the ability to get electrons and then computing power. Well, what about patients? What about the patients? Do they care that a machine is looking at it? Turns out when you give them a survey, and if they get, just like anything, if you have a good conversation about what's going on, most of them in this little bar said after the survey, like 70-something% were totally fine with it. Once they understood, and I'll be honest with you, me, what does the computer say? I mean, what does the computer say? Look at my eyes and what does the computer say? I'm curious. And then ethical considerations. What if the clinician and the computer disagree with each other? Remember the story about the lady, I think it was a lady who put her image MRI into ChatGPT and it got something different. No, it turns out she has cancer. It's a little bit of an extreme example, I hope, but it's in the news. What about costs? The no-tile home OCT, what we're doing? I mean, you get a little bit more of a reimbursement for that than you do the OCT you do in your office. So, computing power, electrical power, and then one question that I haven't heard get asked at the talks, but should we even be doing this? Just because we can, does that mean we should? It's just something to consider. And I put a talk together in 2022, and I was just information, not a big deal. It's fine, clinicians, but then I do it now, and I'm recognizing how my mind has changed in the 3 years. AI can build AI now. Is it going to replace us? Back then, I'm like, no, give me a break. That's not going to happen. Now I'm like, no. But it can. You know, it's just, I'm not saying it is. I'm just saying it's better than us at reading those images. If I'm a patient, I'm going to go, what does the computer say? That cannot go past us with what we do every day. So, HIPAA, privacy, that doesn't change. We need to respect people's privacy always. Is it a replacement for a clinical specialist? We'll see. Let's zoom out a little bit. Why do we even need to discuss this? Does knowledge matter? Does it really matter? If you have access to all knowledge of all time in your pocket for free, I mean, I used to argue with my mom and say, why can't I use a calculator? Do I need to show my work? Are you serious? I mean, the calculator's not going away. Why? I just going to use it. Well, I'm having the same discussions with my kids. It's like, I just chat GPT. Okay, go ahead, sure. You are going to get stupider, or you're going to learn how to critically think, and it's going to accelerate you. I really think that you're going to start seeing a divergence in society because of that. People who can critically think and challenge themselves to do it, and then, all right, oh, what are we doing? Give me the answer. Sorry to be crude. Not sorry. Real-world data versus clinical trials. This was kind of a big thing, and still is, like, what does the real world say? None of that matches the clinical trial data. And for me in my world, I go, the patient's like, I don't want you to stick a needle in my eye. Well, you're going to go blind. Isn't that my call? I'm like, yep, sure is. I mean, if I do it against your will, I think that's called assault. I don't want to do that. So I love not being in prison. Let's not do it. Okay, great. Your call. Let's do this. And the data in the clinical trials don't have that because you've super selected the right people to fit your inclusion, exclusion criteria, and you cut out the ones who don't finish the study. So that's one thing to think about. AI will do a better job looking at that. Is this a good thing? Yes, with an asterisk. Why not? These are things just to think about. Does it freak you out? Is it a threat? I think it's a threat if you let it and if you think about it that way. I look at it as a tool. I encourage our team to do it, and I encourage people to share prompts with each other because we've come from a query-based thinking where we put in a query to Google, give me this information on that. If you do that in ChatGPT, it's just going to do the same thing, but a prompt is very different than a query. Look that up. Is it a threat? We talked about that. Okay, zoom out. And here's how I think about this. Everything we're talking about in ophthalmology and artificial intelligence is ANI, artificial narrow intelligence. It's a single task-focused application. Diabetic retinopathy, convolutional neural network, reading these images, data set, trained there, go there. Well, what about AGI, artificial general intelligence? That's human level reasoning adaptability across all subjects, everything, all subjects. The smartest thinker, the best writer, mathematician, scientist, ophthalmologist, anything. That's artificial general intelligence being able to, function at human level on all subjects. That's where things are going. Right now, that's where they're getting. ASI, still hypothetical and theoretical, but a lot of the researchers believe in 3 to 6 years they're going to be there, and that's greater than the sum of all humans. Interesting concept. Examples: diabetic retinopathy, cameras, artificial general intelligence. It'd be able to write a novel, anything you can think of, being able to perform at human level. That's AGI. ASI, we can't even think about it, but it's far superior and more than what humans can do. Still theoretical at this point. So, this question was posed to researchers in 2022. What probability do you put on humans' inability to control future advanced AI systems causing human extinction? I thought this was a joke. Or the similarly permanent and severe disempowerment of the human species. Surveyed to 700 or 735 or so researchers in machine learning. Over 50% of them said there's a 10% or greater chance humans go extinct. And then the follow-up was like, well, what are you doing about it? And they're like, we don't talk about it. We don't talk about it. This was in 2022. So there are lots of people now talking about it. There are organizations, Gladstone AI, the Center for Humane Technology, I think Tristan Harris and that group, they're doing things. It's not covered up. People are talking about it, which makes me feel a little bit better. But one other quote from Tristan Harris there was, if you optimize for a narrow goal or a single outcome without consideration of the whole, that in and of itself sows disconnection. That leads to disconnection. So if we go down this road without consideration of the whole, we get into some problems. AI is here. It's coming. We're not going to stop it. And we're going to be forced to confront our purpose. Not like, what is my purpose in the clinic? No, as humans, as people, what is our purpose? It's forcing us to think about those things. What is knowledge? Remember, define those terms. We have to define those terms. We're being forced to. What does it mean to be intelligent? I can think of some people and go, that ain't it, right? Other people, I go, that's definitely it. So, Eric Schmidt, former CEO of Google, he gave a talk recently. The industry, the AI industry, they believe that right now, a little over 20% of all the computer programmers, that's AI being done. And within the next year, they believe it's going to be 100%. No more computer programmers at all. It's all going to be AI. So within a year, they also believe that you're going to have top-level, best mathematician AI agents. You take computer programming, math, that's the foundation, the basis of the digital world. Now you take that and you scale it up, and there's a term called recursive self-improvement, I believe. That's where AI learns to get better on its own. It teaches itself. You scale that up, that's when they think 3 to 6 years, you get to ASI. We don't have any understanding of what that even looks like. This is coming from him, the former CEO of Google. And that's the rabbit hole I went in. I'm like, oh my God, what am I going to do? I better grow some vegetables, get some cows, and became a prepper, even more than I already was. But I think, at the end, I'm like, you gotta have a positive thought at the end, right? I go back and I think about the conversation I had with Scott, and he challenged me to think and look at this and watch this nerdy documentary that, got me all stirred up inside. And it really comes back to technology doesn't help people. It helps people help people. And at the end of the day, that's not going to go away. I believe that's not going to go away. That'll be really cool. And the cyborg can come, and I'll just be like, hey, look, these are my friends, and we're happy, and we're going to help each other, and I don't need the cyborg. But at the end of the day, you can't take that away. You can't take away the fact that you walk into a room with one of your patients, you love them, they love you back, and that's really what matters. And I don't know how to quantify that, I don't know how to measure that, I don't know how to put that in a machine. So, thoughts, questions, comments? We got a little bit of time, right? Will?
How much AI did you use to help you make your lecture?
I thought about it. I made 3 lectures. I was like, okay, AI. Yes. So I did. I thought, let me see what this does. Boom. So at the end of the day, I go, I can't, so my story, that's mine. I can't get that out of ChatGPT. I mean, hopefully you saw a little bit of a personal stuff to it, but I made 3 lectures, not this one. And I looked at it and I go, that's cool. And then I even went back and said, do one, because Richard Chu, I don't see him, but he would always make these, he would spend so much time, and it was like a movie every time he would do a presentation. And I'm like, mine is white with black letters. I can't do that. And so I said, do one with more animation. It was like a movie, and it was like Richard doing it. I'm like, ugh. So at the end of the day, yes, I did it, but not here. I wanted to be able to talk, I wanted to be able to tell a story and interact, and thank you for asking that. And also, I don't appreciate that. I think you had your hand up.
Thanks for sharing that story about your mom telling you not to use a calculator because you wanted to show your work. What do you think the role of AI in ophthalmology residency training or even for medical students is? And then the second part of that is, how do you not use AI and not miss out on it as a trainee?
Good. That's a great question. So I answered that. I had the conversation with my daughter, and I said, you can be stupid or you can't, because it's an unbelievable tool. And so if you learn what a prompt is, and if you learn how to critically think, so a good example, I gave this to my daughter, is write your paper, and then turn around and put your paper in there and use it to say, edit my paper in such a way that these are the outcomes I want. You've already done the paper, you've done the critical thinking, it helps you think differently. Then rewrite your paper. Like, choose to do the work. I would say the same thing with ophthalmology residency training. A lot of it is, I don't know, but I'll find out. You go home, you read, you learn, you figure it out, you come back the next day, and then they never ask you that again, right? You just have to add it to your repertoire of knowledge. I would say embrace it. I would say you've got another attending right there that has access to all of that data. This is what I'm telling our team at work. I'm like, everything you do, you better figure out how to do it better. And one way to do that is come up with what you need to do and then use that tool to help you do it better. Another one, my son, he's studying for the ACT. Design for me here are my strengths, here are my weaknesses, here are my previous scores. I want to strengthen these areas. Design for me over the next 10 weeks a study program that will highlight my weaknesses and help me improve that so that my score gets better. You've just flipped it around to where if you go in there with your computer on the ACT and plug in the question, you'll get it 100% on it. But if you go in and use that as a study tool to get there, that's what I've done with my kids, and I think about the same thing, because if we define what is learning, it's painful. Growth is painful. Healthy things grow and growing things change, right? Growth is painful. Ophthalmology residency, painful. Necessarily, right? That's what I would say. Surgery-wise, too, there's actually AI programs to help you in surgical training and everything. So it will recognize things you're doing before you even do it. It's not there yet, but it's getting there. Joe?
In a practical way, solo ophthalmologist, I take a retinal image. How do I prompt AI to give me their impression?
Of that image?
Yeah.
I would do it exactly like you're presenting it to your attending. Or you can say, here's the picture, I don't know. This is what I do. So iNook does it, and it's a company you can do, but ChatGPT or Grok or any of the platforms, if you put it in there, I'm not sure which one's best for imaging. I don't know that. But what I've done is I put in the picture and I say, here are the things that I see. Is there anything I'm missing? And it helps fill in the gaps. This is a 55-year-old white male smoking whatever, and put all that in there. Don't put their name and address.
Follow up on that. So you're saying you don't necessarily need some fancy gadget from Calcutta or whatever. We can just take the pictures that our machines are already producing and load them into ChatGPT or something like that and tell it to analyze it and give us.
You can do that. How reliable that is, I would. The companies are doing things and running it through their convolutional neural networks based on a data set that's been trained. The ability to just jump in your clinic and do it on one of those platforms doesn't exist, not in a meaningful way. But it's kind of like if you looked up a patient with birdshot retinopathy and you Google image it, that's what you're going to get. And what's out there on the internet, you're going to get in a concise way. These companies are putting together trained data sets to be able to give you, relative to that trained data set, what that image you put in looks like. Hopefully that answered that.
How does this work with malpractice?
I don't know.
I mean, you had mentioned something about missing a can or whatever. How do we use that as a, I guess, educational, learning? Is it a defense? Is it a, I use that to help me make a decision?
I wouldn't do that.
You see what I'm getting?
Oh, I see what you're going.
Because we have patients that come in and go, no, that's what I have.
Oh, yeah.
Because I Googled it or I looked at the symptoms and the signs and this is what we're seeing.
Yeah, I wouldn't do that. I wouldn't say, yeah, I Googled it. I stayed at a Holiday Inn Express. I think that's a bad idea. And seriously, I think it turns out to be the same thing. But to do it in your office and figure out and learn and see, it's just like Googling it yourself because the patients are doing that. They're doing that. No, I haven't seen that at all. And it's being sorted out is what our attorneys have said. That's being worked out, which means don't do it. It means we don't know. So, anything else? Yeah, Daryl. Yeah. I think that's a good use. It helped you do something you needed to do more expediently, right? Well, another one is I created a software program to help me find all of the books on a certain subject and how and where to buy them as cheaply as possible. I did that. And if anybody knows me, I'm not a software person, but I put all that in and got it. Now, I don't know how to use it because apparently you have to have a program to work. But I did it, and I have all the code. It turns you into a machine, literally, of doing things that you couldn't otherwise do.
Do you foresee AI outpacing current clinical training for ophthalmology residency? And if so, how can we avoid that situation?
Use it as a tool. Do I see AI outpacing in one sense? Right. So the scary thing is it's already there. It's already better. It's already better than all of us at recognizing that, diagnosing disease. Does that pose a threat? No, because I really genuinely believe at the end of the day, people are going to want people to take care of them. So I would embrace it as a tool and learn better with that as a tool. I don't hear with a lot of the companies I've talked to, and I've had a bunch of discussions with them, I don't hear any interest at all in these companies replacing doctors at all. It's like, I think I'm the only one who said that.
Training formally in any fashion?
Oh, I think it's happening. I think, yeah, some of the bigger programs are putting these things in and having it there and learning. And so I would think embrace it along the lines of find out research. If you do a research topic, tailor it into the computer science aspect of how AI can do things. I think that's where our mind needs to shift. This isn't, when OCT came out, it's like, you better have it. Same thing. What are we doing here? Let's use this as a tool. How can we use it better and differently? That I don't foresee any time in the near future in my career, my lifetime, where it's going to render ophthalmology, eye care unnecessary at all. But it's pretty cool technology. There was another question, I thought. Maybe not. Are we out of time? I've got a slow, soft, gentle nod, yes. So thank you for the attention. I appreciate it.